Good morning. Thank you for the opportunity. Thank you, Dr. Shaw, for inviting me. My name is Steve Maximus, and I'm at UT Houston. There we go. I have no disclosures. So thoracic stent grafts and aortic repair has supplemented open surgery in many specific aortic pathologies, particularly in the descending thoracic aorta. Open total arch repair is still the gold standard for most low-risk patients with ascending and arch aneurysms. However, endovascular arch repair is an option in high-risk patients with aortic arch aneurysms increasing in use. So I'm first going to touch upon zone 2 repair, then I'm going to go to zone 0, but 20 to 60% of TEVAR patients require landing into zone 0 to 2 with coverage of at least one supra-aortic trunk. So zone 2 TEVAR without or with left subclavian artery vascularization, you can see there's a significant complication rate when you cover the subclavian in terms of stroke, in terms of spinal cord injury. There's no difference in mortality, most studies show, but in terms of long-term, I think that mortality rate is increased. As we know, stroke and spinal cord injury long-term do affect mortality. So, on the other side of that, if you try to spare the subclavian and you shorten your sealing zone, we know that that's an increased risk of persistent false lumen flow, type 1A endo leak, retrograde dissection, and thoracic enlargement. Stable trials show this. Basically, you have an increased complication rate if your sealing zone is anything less than 10 millimeters, and even in that 10 to 20 millimeter sealing zone area, you have more complications. Really, you want about 2 centimeters of seal if you can, and the key here is in parallel aorta. So society recommendations all recommend basically preserving the left subclavian when you can. This is a grade 1 recommendation, and basically what it says by the SVS is that when you can preserve the left subclavian, at least in elective procedures, you definitely should. In emergent procedures, if you need to cover the subclavian, you should consider revascularizing it when you can if the patient has any issues. Same thing from the ACC, AHA guidelines, a little bit different. They do say placing a lumbar drain if the patient has spinal cord issues in the case of subclavian artery coverage, if you can't do left subclavian artery vascularization. So the Gore thoracic branch endoprosthesis, this was FDA approved in May of 2022, and the first implants for commercial use were in August of 2022. This was the 3-year follow-up, 40 patients from the original trial. The median follow-up was 3.8 years. They looked at 3-year follow-up basically, and basically what they found was there was no aortic-related deaths, there was no migration, fracture, reintervention rate was freedom for intervention was 97%, so very good. And there was only one branch occlusion. That was in the original 30 days. In the long term, there was no further branch occlusion. There were no aortic-related mortalities. This was an experience. This is a multi-center study between 7 institutions. We had 107 repairs for urgent or emergent indications. This was acutely complicated dissections, ruptured aneurysms or pseudoaneurysms, and then blunt thoracic aortic injuries, so really usually sick patients. The results of this were technical success in all but one patient. There were 5 retrograde dissections. I think 2 of them were due to inadvertent coverage of the innominate or the left carotid artery. 30-day mortality was 2%, so quite acceptable in a very sick patient cohort. And the cumulative aortic mortality, or there wasn't long-term follow-up addressed in this paper, was 3%. Major adverse events were about 18%, with spinal cord ischemia at about 6%. So pretty acceptable for a very high rate of complication traditionally cohort. Zone 0 arch branch devices. So there's the Gore TBE, which I touched base upon, can be used as a zone 0 device, although that is off-label. The Nexus EndoSpan device, which is still clinical trial, although they're finishing up that trial. The Cook A branch and the Bolton arch branch are the devices. So high risk for open arch repair. There's a lot of things here that make you high risk. Basically, this is probably most of our patients, most vascular patients we see. Age over 70, prior surgery, COPD, CHF, pulmonary hypertension. There are anatomic limitations for zone 0 repair. Short grafts, kinked grafts, angulated anatomy, tortuous access vessels, and then extensive dissection in supraortic trunks. In dissection patients, about 60 or 65% of the patients will have dissection extending into the landing zones in the supraortic trunks. So it does make repair more difficult in those patients. This was a study from the European Journal of Cardiothoracic Surgery in 2016, and they wanted to look at was why are ascending grafts unsuitable for endovascular repairs, and what they found was 30% of ascending grafts are unsuitable. 30% of those were unsuitable because they were excessively kinked, and the other 70% were due to short graft lengths. So really, it's important to make sure that your cardiac surgeons are on the same page, and this is where a team approach comes in, that make sure that they set you up so you can have success in the future should you need to do a zone 0 or endovascular repair. So there's single branch devices and multi-branch devices. There's the Gore TBE and the Nexus Endospan. The advantages of the single branch devices is there's less arch manipulations. You have potential for single branch cerebral protection, and they're high flow. The cons are cervical debranching, carotid bypass can be a morbid procedure. The patency is based on a single vessel and the retrograde configuration in the TBE device. There's component separation issues with type 3 leaks in the Nexus device. Cervical debranching, carotid bypass is tunneled retropharyngeal. There can be a significant dysphagia rate with that. Early complications are wound infection, hematoma. Phrenic nerve is reported at 25%. I would guess it's probably higher than that. I don't think it gets reported as often as it recurs, and then the other infections. Graft infection, 1%. The feasibility trial, the original 40 patients, 9 of those patients were zone 0. The stroke rate was 25%, although I will say it's a small N, right? It's 9 patients, 2 of them had strokes. The Nexus Endospan arch device in their feasibility trial, 28 patients so far, 30-day mortality was 7%, and stroke was 3.6%. So they did have more patients with a lower stroke rate, and their 1-year stroke mortality combined endpoint was 17%. And there's double and triple branch devices, the Cook device and the Bolton device. Advantages here, there's no cervical debranching, and you can do this with antegrade or retrograde branches, depending on how the device is built, and you can do this totally percutaneous. There is more arch manipulation, which will lead to more stroke, and these are less forgiving due to ascending aortic graft kinks. The schematics of these devices, it comes in 34 to 46 for the Cook device, Trumos 32 to 48. I won't go through all the details. You can get the Cook device with a preloaded catheter. And then the main thing to it where you hear the anatomical criteria, the length from the sinotubular junction to the innominate artery and the Cook branch needs to be 50 millimeters, and the tumor relay is 65. So it's pretty long distance. And you have to have the absence of kinks or atherosclerotic debris. And this is just to touch upon, this is the same thing that Dr. Odrich alluded to in his talk. You really need to have these cases addressed with an aortic team. You need specialized centers that provide both open endovascular with cardiac and vascular surgery on site, and you need to have people who are experienced in both open and endovascular arch repair if you're going to do these cases. So in conclusion, zone 2 repair, coverage of the left subclavian artery should be avoided, and we've shown that the Gore TBE device can be used safely in acute aortic pathology to save that left subclavian artery. Open arch repair is still the gold standard. That's probably not going to change anytime soon, but endovascular repair is an option in patients with high-risk aortic arch aneurysms. Thank you.